So let's talk a little bit about anterior knee pain, something that we all see, that everybody sees. I like to get my disclosures out of the way right away. Everyone who's seen me talk knows that my disclosures include that I have an irrational fear of sharks, particularly pool sharks. I probably have an irrational fear of this guy's suit, but I'm not 100% sure yet. And based on this picture, I probably should have an irrational fear of baby camels. The way that guy's looking at me, but I don't. Dr. Oliver's right. My career has kind of taken an interesting turn. I'll give you a quick background. I graduated from Northeastern in '92. A few years after that, I became board certified as a sports specialist. A few years after that, became certified as a strength and conditioning specialist. And then in the late 1990s, I got the opportunity to do some traveling and teaching and talking about ACL reconstruction, ACL surgery with Charlie Brown, Dr. Charlie Brown out of the Brigham. And we did a visiting program actually in the United Arab Emirates in Abu Dhabi. And we did a program that we would go 3 or 4 times a year, and we'd do about 40 or 50 ACL reconstructions. Then I would stay behind and sort of train the locals how to take care of the patients. And then we go back in 3 months, check on that group, and we do a whole nother group. The rate of ACL tear in the Gulf, we estimate, is about 5 times higher than what it is here in the general population per exposure. And there's a lot of really interesting things about that. That's a talk for a whole nother time about tibial slopes and cool stuff like that. There's such an epidemic of it that in 2006, Charlie came to me and said, hey, I'm going to move there and build a hospital. You want to go? And I said, okay. So we went over, and so we built a sports surgical hospital, and the hospital is called the Abu Dhabi Knee and Sports Medicine Center. Is now called Health Point. If you want to look it up, it's a really beautiful place. It's a multidisciplinary specialty hospital now. We came home for a couple of years, and then in 2014, I went back with him, and we did a private venture called the International Knee and Joint Center, which looks a little bit like this. So this was the clinic that we got to design over there. So from my perspective, it was sort of a dream come true, because I walked in and they said, okay, we want to do ACL reconstructions and meniscal repairs and cartilage transplants, and we want you to build a clinic, and we want you to do the rehab protocols and hire the staff. And I said, okay, what's my budget? And they said, you don't really have one. So we kind of got to do everything we wanted from the very beginning. So it was a really interesting turn in my career. I could talk about ACLs all day, but I decided to pick something that we probably all see a lot more of in our clinic, and something that for me has been an incredibly frustrating thing to treat, especially early in my career. That's patellofemoral pain, or anterior knee pain. We see it, right? We see it all the time. It's the most common thing that we see in our clinics. It's one of the most frustrating things to treat. 40% of all knee problems in sports medicine clinics, up to 25% of all running injuries, over 2.5 million people a year. When I first came out of school in the early 90s, and they tried to explain to us what it was, they said, oh, it's just painful cartilage, right? The back of the kneecap hurts. But we know that's probably not the case, right? Cartilage is avascular, it's aneural, it probably doesn't hurt. And we look more at the subchondral bone that's traumatized with high compressive loads and high impact loads. Why we get it is kind of what we're going to talk about today. In 2013, a bunch of people a lot smarter than me got together in Vancouver and had what they call a patellofemoral retreat. And that was Chris Powers and Jenny McConnell and sort of all those guys. And they came up with some consensus statements for kind of what is and what isn't patellofemoral pain. And we know that it can come from too much activity. We know it can probably come from too little activity. We know they can come from sort of high-risk activities, right? But there are some things that we've sort of historically been told that may be contributing factors that may not be. So we'll kind of review some of that stuff today. Ultimately, what it comes down to is a force distribution problem, right? So I'm a biomechanical guy, so we're going to talk about biomechanics a lot today. Don't you fall asleep, Leah. All right, so but it's a contact area problem. So you're talking about a joint that has these incredibly high compressive loads, and based on the type of activity you're doing, relatively small surface areas to disperse that load over. If you look at the compressive loads on patellofemoral joint, or joint forces in the patellofemoral joint, just in basic everyday things that we do, walking and biking, we all know pretty safe for the patellofemoral joint. The load's not too much. When we get up into higher impact activities, squatting, and particularly deep squatting, the numbers go through the roof. So 4,000 pounds of contact force through the patellofemoral joint if you do deep squatting. Add load to that, it gets worse. There are reasons for that biomechanically, which I think are important for us to understand when we design treatment programs to rehabilitate our patients, and when we teach our patients about why we do that. So if you look at patella contact forces, right, throughout the range of motion, this is a diagram you probably have all seen. Whoops, I don't want to go too far ahead. That we've all seen. At 90 degrees of flexion, you have actually the sort of largest surface area contact on the retropatellar surface in a relatively normal patellofemoral joint. Between 45 and 90 degrees, you have this big surface area contact. At 20 degrees of flexion, you have this really small contact area. That doesn't matter if it's open or closed chain situation, by the way. So that's important to remember when we talk about biomechanical loads. What we know is that if we apply a high compressive load to a small surface area, that's a bad thing, right? So big force, small surface area results in really bad stuff. My favorite part of this is the guy smoking the cigarette leading the horse has no idea his buddy has 2 collapsed lungs, like sitting on the street behind him. If forces are equal, right, across the patellofemoral joint, patient to patient, why do some patients get injured? Why do others just seem to persevere no matter what happens to them? I think you need to look at everything when it comes to the joint. The first is the inherent joint morphology, right? So we're talking about a joint that's relatively unstable. It's got a shallow trochlea, depressed lateral condyle, relies heavily on dynamic stabilizers. We know that system is not a great one when we look at the shoulder and joints like that. And then there are these wide genetic variations even within that model. So this patellofemoral research retreat in 2013 with McConnell and Powers and those guys, they sort of, essentially what they did was they went through all the literature that was available on anterior knee pain at the time, and they sort of summed it all up for us. And one thing they did find is that in the case where we have abnormal patella mechanics, if you have particularly instability, patella instability, so these 2 studies, 2010, and then this cohort study in 2013, patella alta, abnormal trochlea, higher incidence of patellofemoral osteoarthritis and bone marrow loss. Okay, so we're talking about that subchondral bone in these knees that have more patella instability. Here are a couple of CT scan representations. So you see on the left, and we see normal patellofemoral contact at the different joint angles, okay, 30, 40, 50. We see the large contact area here of the retropatellar surface. If we see here in a patient with a recurrent patella dislocation, look at the contact area. It looks like it's about 1/3 or 1/4 of the contact area behind the joint. So if you apply the same force over this area or over this area, guarantee this area is going to break down first, right? Biomechanical consideration. So this is the stuff they pounded into us in school, right? Oh, you got to look at Q angle, because if they have a static Q angle greater than a certain amount, then they're predisposed to patellofemoral pain. Dynamic valgus, which we'll talk a lot about, that's come into fashion more. Flat feet, muscular tightness, weakness, all that stuff. Interestingly enough, the research on Q angle is sort of mixed. So you'll find some research that says that there is no correlation between static Q angle, regardless of what it is, and the onset of patellofemoral pain or the incidence of it, and some that say that there is. The consensus report from the patellofemoral retreat was that Q angle probably is not a contributing factor to, not a risk factor for patellofemoral pain syndrome, right? So you can take it off your evaluation now. Rear foot eversion, okay, so flat feet. Somebody's got flat feet, that starts the dynamic valgus cascade. So plenty of studies, we're looking back 2001 all the way to 2011. There does seem to be some correlation between rear foot abnormality and patellofemoral pain, but not enough to denote a cause and effect between the two. I think that the flat feet probably does play a role in sort of this dynamic valgus phenomenon that we'll talk about that lateralizes the patella. But you're not going to look at these patellofemoral patients and just because they have flat feet, put them in a custom orthotic or something right away. Okay, I think that's what we take from that. So here's the meat and potatoes of it, right, is what we call dynamic valgus. We talk a lot about it with ACL injury as well. But it's this cascade that starts with rear foot eversion, right? So from there you get distal tibial abduction. The femur drops into adduction, internal rotation, and that lateralizes the patella. Okay, so this is in weight bearing. This is a pretty dramatic representation of that, but it's in any weight bearing when someone hits a single leg stance and they drop into that position. So if you have increased lateralization of the patella, you're going to have these increased patellofemoral forces that we saw earlier on some of those slides. Here's stuff from Chris Powers. Actually did a whole bunch of good research with motion MRIs out at USC. He actually did a lecture in Dubai at a course that I did a talk at. I talked right after him. I had no idea who he was. I would have corralled him and picked his brain for 4 hours if I had known. But he did a great talk on this. And if you look at these two, so here's an MRI, a motion MRI of this guy in this position. Here's this guy in this position. Look at the patellofemoral contact with this guy in valgus, dynamic valgus, and this guy lined up right here. So you can see the dramatic difference in surface area contact of the patella and the femur. Okay, that's really important, I think, when it comes to designing your exercise program. And sure enough, if you look at the research, which they did out in Vancouver, the study's 2010, Powers, this is Chris Powers' study in 2010, Myers' study, Davis' study 2007. Essentially, these link dynamic valgus or weight-bearing valgus with lateralization of the patella, and then with patellofemoral pain syndrome. So there's a pretty good link there. And we're going to talk about sort of how to combat that a little bit toward the end of this talk. But the other basic stuff, IT band tightness, right? Every patient that comes in has a referral from their doctor, stretch their IT band, stretch their IT band. Why? Well, because probably there's one study that the retreat found. It was done by Wu's group in 2004. And all they did essentially was a surgical release of the distal IT band tract. And 4 weeks later on radiographs, it looked like they had better patellofemoral alignment, these patients. There were no follow-up studies beyond that as to what happened to their symptoms. So there probably is some mechanical consideration with a tight IT band. Hamstring tightness, right? You always get that in your scripts too, stretch their hamstrings. Everybody has tight hamstrings. The idea behind that would be that if you have someone has tight hamstrings and they're trying to walk or run, if their hamstrings are too tight to really allow them to extend the knee into full extension at heel strike, then they land on a flex knee, more of a flex knee, which gives you a shorter distance to distribute forces, impact forces over. So more load on the patella. Sure enough, if you look, there is some research that would indicate hamstring tightness and a correlation with patellofemoral pain, right? So we definitely want to keep stretching hamstrings. So that's stuff that we already know. So here's the big one, right? So weakness. When I came out of school 100 years ago, anterior knee pain, strengthen their VMO, right? Just pound away at that VMO. If you get their VMO stronger, you'll get them better, right? So for the first 4 or 5 years of my career, I pounded away at people's VMOs, and nobody got better, right? And I couldn't figure out why. And then I started to get frustrated and say, okay, strengthen their VMO. And I started to say, well, how? Like, how do I strengthen their VMO? Their quadriceps is turned on by one nerve, right? So the femoral nerve turns on the quadriceps. I got 4 bulbs in that light. I got 1 switch on the wall. How am I going to turn the left one on and not the right one at the same time? So we know that there are activities that actually will turn on the VMO, or you get greater EMG activity out of the VMO, but you get it out of the whole quadriceps. You're not able to isolate to create balance of any kind. So that stuff kind of got frustrating, and there's now mounting evidence that you can see that there really isn't much of an activation pattern problem in patients with patellofemoral pain and not. And this is a study in 2013, a nice recent study by Patton's group that showed with motion MRIs and EMG, no difference in quad activation patterns in patients with and without patellofemoral pain syndrome. So we started looking more at the hip and core. I think that's sort of become mainstream now, that hip and core strengthening is really important in pretty much everything that we treat as rehabilitation specialists, but in particular in the treatment of anterior knee pain. And there are lots of studies, again, going back 2005 up through 2009, and Chris Powers' studies aren't even in this slide, but looking mostly at females, right, because we see women with a lot more incidence of this stuff, and there's a strong correlation between hip weakness and patellofemoral pain in females. Okay? Weak hip external rotators, weak abductors, weak core strength, so that when these guys land, when they're running or jumping, when they land biomechanically, they fall into that dynamic valgus position, even if it's just a little, but they do it for 10,000 steps. And you lateralize that patella for 10,000 steps because the proximal segment is not stabilized. Not because the patella is not stabilized by the quad, but because the hip and the femur are not stabilized by the pelvic and core musculature. So if you look at all these, you can see, every time someone jumps or squats on a single leg or comes down when they go into that valgus position, you're going to get lateralization of this patella. And that's a result of sort of that femoral internal rotation and adduction. And the third thing we look at are high-risk activities. So if you're going to do activities that are high risk, there's a potential that you're going to get hurt. I could go on for about 40 minutes about CrossFit. Any CrossFitters in the room? I don't want to alienate anyone. I love the concepts of CrossFit, right? I love the concept of metabolic training. Ask the people that I work with. I kill my high school kids with these metabolic circuits and stuff. It's fantastic. We finally figured out that we can actually drive cardiovascular fitness with strength training, right? We thought for years you had to train every system separately. So when I played soccer in college, I had to do distance on one day, sprints on another day, strength on another day. It was ridiculous. Now we realize that we don't have to do that. We can drive heart rate and train both oxidative and non-oxidative energy systems with strength exercises, right? That's fantastic. That's the biggest breakthrough in fitness in 50 years. But the problem is that when we don't take into account biomechanics and what biomechanics do to vulnerable tissue like meniscus and cartilage and tendons and things like that, we get into trouble because we create these incredibly high loads and high volume and high repetition in an attempt to sort of improve strength and fitness. So I see lots of these guys in my clinic. I'm sure that you guys too, with everything from knee pain to labral tears to meniscal tears. Even standard training, we try hard to train our patients that, we should be limiting motion to some degree if you're dealing with patellofemoral pain. Maybe things like deep squats aren't such a good idea to do, right? At 90 degrees, you got great surface area contact, but you have ridiculously high compressive loads, and particularly in a closed chain situation like this. Open chain's a little bit different. We'll kind of talk a little bit about each one as we go forward. So I think for me, patellofemoral pain or anterior knee pain is kind of you take all these things, you throw them in a glass, you swirl them around, and what comes out the bottom, patellofemoral pain. So you have to look at all this stuff, and you have to look at what you can change, and as a rehabilitation specialist, what you can't change, right? The strategy really should be this. If it's a load force distribution problem, the strategy should be improving mechanics, improving congruency, and that results in improved force dispersion. So we want to reduce this dynamic valgus, but we need to reduce patellolateralization, but we need to do it proximally, not distally, okay? So if we cycle back through the stuff that we talked about earlier, from a treatment standpoint, stretching makes a lot of sense for IT band, hamstrings, and there's a million ways to do that. I could stand up here for another 40 minutes and we could talk about specific exercises, but you guys all know all those exercises, so there's no point in going through them. Reducing dynamic valgus, that's your big one, right? So rear foot eversion, you can try all this stuff if you want to, footwear, arch taping, orthotics, that's probably not gonna fix your problem. Your problem lies right here, okay? Posterior lateral hip and core strength, glutes, abductors, external rotators, okay? And core too, don't forget just general abdominals and low back. That stuff stabilizes the pelvis, which gives your hip musculature an anchor to work from. So you need to do core strengthening. A lot of this stuff falls in line with all our ACL injury prevention training too, by the way, if you guys are up on that stuff. So I use a combination of closed and open chain strengthening. I just make sure I'm careful about biomechanics. If you want to read more about biomechanics and exercise, this guy, Rafael Escamilla out of Duke, he's in the Human Performance Lab at Duke. He's done a ton of great studies about biomechanics of exercise and joint compressive loads, things like that. Kevin Wilkes done a lot of that stuff too. Doesn't do as much of it anymore. So these studies looked at the patellofemoral mechanics during squats. And what we find, the general consensus when we look across the board, is that as you increase the knee flexion angle, your patellofemoral joint forces increase. That's the bottom line, right? So you get a bigger surface area between 45 and 90 degrees in terms of contact, but your compressive load becomes dramatically higher. So that offsets that bigger surface area. So deep squats really don't make a lot of sense if you have somebody that has anterior knee pain. In the open chain situation, it's essentially the opposite, right? So you have higher patellofemoral joint forces closer to full extension based on these studies. The reason being that in that last 20 degrees of extension, you have this tiny, tiny, tiny little area of contact, right? So even if the joint forces aren't as high, if you can't lift as much weight, you're distributing it over such a smaller surface area that it results ultimately in a higher joint force. Okay, so when we talk about standard training, closed chain, we want to teach our patients, at least initially, not to squat deep. 45 degrees is where you get good contact, big surface area contact. The joint load's not that high at 45. So I teach my patients initially when they're doing closed chain exercises from 0 to 45, okay, closed chain, and then load the weight. Add weight, make it harder, make it harder. As long as I keep them out of valgus and I keep their flexion angle short, I can usually mitigate their symptoms. I like closed kinetic chain exercises too because of the functionality of it. Obviously, it's functional. You can add a lot of instability. You can add a lot of other components to it to make it harder. I think open chain has its place. I think standard leg extensions really don't have much of a place in patellofemoral rehab. Some people use them, I don't. But I think when you talk about hip and core strengthening, I think you can do lots and lots of creative stuff with open chain exercises, okay? Hips and core in particular. So I think if you're going to get anything out of this takeaway-wise, I think you just look at this. Remember, there are things that you can't change as a rehab specialist. You can't change their inherent instability. You can't change their individual joint morphology. Even if you wanted to look at their Q angle, there's nothing you can do about it, right? Rear foot eversion, maybe you can influence it, but it's probably not going to make a big difference. Here are the things that you can. General activity or inactivity. So a patient who comes in who has anterior knee pain, who sits on the couch all day and doesn't do anything, just start to get them active. Getting them active will start to make them feel better. Look at training programs. I sit down with every single one of my anterior knee pain patients and I go through their whole training program. Whether they're training at home, training in the gym with a trainer, they're going to CrossFit, whatever it is. And you can start picking pieces out of that right away to change what they do and re-educate them about what they do. Muscular tightness, then muscular strength. In particular, again, hip and core. I've said it 1,000 times, I'll keep saying it. So for me, modalities, I was going to get up here and do a 40-minute talk on ultrasound, but I don't use a lot of modalities, and most of what I do is exercise-driven, biomechanically driven. I think you use them if you need them, but I think in most patients you probably don't need really a lot of modalities to treat this stuff. Functional closed kinetic chain exercises for me really where it's at, right? Limited squat depth to keep patellofemoral compressive forces at a relative minimum. Open chain stuff for hip and core, and I do tons of it. And I for my fitness patients who really want fitness at the same time, I teach them how to do metabolic training with the exercises that I give them to strengthen their hip and their core. So your patient comes in, they got red hot anterior knee pain, right? You can't do much with their quadriceps, but you can crush their hip and their core because it doesn't hurt, and it doesn't hurt their knee. Better for them psychologically. They see they can work hard, that their knee's not gonna hurt as a result of it, and they start to buy into what you're doing, and they'll just work harder and harder for you. So I teach them, a lot of them, how to do sort of circuit training, metabolic training on their own, 6, 7, 8 stations. I include non-impact cardiovascular intervals into those stations sometimes to try and drive heart rate and fitness. So that's something else that you can teach them. Don't run for a little while, get on the elliptical trainer instead. Take it a step further, don't do 40 minutes on the elliptical trainer, do 60-second intervals, at 95% target heart rate, stuff like that. And then pushing the heck out of their core and their hip strength. And I got to say, I started doing a lot more of this when I was in Abu Dhabi, and anecdotally, much happier the results. Much happier with them here as well too. I think the focus on hip and core makes a huge difference for me and for our clinic. That's it. Thanks. Unless you have any questions.